to it. Chuck has been highly active in the American Medical Directors Association. He was president at some stage, many years ago now, before, doesn't want to remember how long ago. And basically, he's also recently been very involved with the Interact programs and trying to stop people getting readmitted to hospital, which has become a big deal. That's what he's going to be talking about. I suppose I should mention that he's really affiliated with some other university that's a freeway stop up the road. I can't remember the name of that one. But Chuck, we're really glad you're here today. Thank you very much.
Okay, thanks, John. Yeah, I'm actually a graduate here. This place brings back memories of sort because I actually was in classrooms right here too long ago. I want to talk about basically value-based medicine. That's a new buzzword in how we're going to be paid. Even if you're university employed and you get a salary, this is going to enter into how we practice medicine. There's good and bad to it, as with anything. You can read objectives later. I'll just jump right in. There's a problem with the way we're paid right now. Basically, we're paid for producing widgets. You see a patient, you get X number of dollars. So the incentive is see as many patients as you can, whether you're providing value or not. Good doctor, bad doctor, you get paid the same. A bad doctor that rushes through a nurse home, sees 30 patients in a day, provides lousy care, gets paid more than a thoughtful doctor that sees 15 patients in a day and provides great care. Medicare has acknowledged that and said this can't go on this way. Managed care plans came up because of this. HMOs were an original idea. There's been a lot of problems along the way, but they're refining it. And there will be more and more push towards this. There's new codes out there, annual wellness exam, transition to care codes, chronic care management codes, and now ACP, starting in January, you can bill up to half an hour for advanced care plan. A wonderful thing. But there's another opportunity to build Medicare. What's a meaningful conversation? Who really needs this? Unfortunately, doctors are not always instilled with ethics and not always instilled with efficiency. And we need to become more efficient, and we need to have ethics in what we're doing to provide the best care for the patient. The winner in the models we're coming up with will be the doctor who's efficient, who provides meaningful, person-centered care, who meets that person's needs. It's basically a good geriatrician. We'll be at the forefront of this because this is what we have been supposed to be doing all along. Medicare hasn't really liked what we've done in long-term care. In long-term care, I'm using the whole thing, post-acute care, assisted living, home health care. Historically, going back to the first part of the decade, some of the metrics they look at to judge us, avoidable rehospitalization in the nursing home, they didn't change. We're at the same level of rehospitalization, about 1 of every 5 people. Not so good. Community discharges from the nursing home, only about 1 out of 4 people leaves the nursing home to go back to the community when they're admitted. You would think with good value-based medicine and really putting effort forward, you could change that. We really haven't been able to. And unfortunately, we're spending more money. That really gets Medicare's attention. When you spend more money to do the same job, things don't look so good. If you wonder where you're spending money, this is where it goes. We spend about $10,000 to $500 a year for every Medicare beneficiary in the United States. That's a lot of money. The variance is pretty wide, about $3,000. If you look at all the post-acute care down to the second to the bottom, it's roughly 16%, 15%. So we control a lot of the budget, frankly. The variance, if you know, for post-acute long-term care is the greatest of everything. It's almost the whole budget. We're all over the place. For example, why does a hip fracture sometimes go home, sometimes go to an LTAC, sometimes go to long-term care? Medicare has a lot of interest in this. Is it just patient desire? Is it community resources? Is it usual and customary habits? You really have good evidence-based medicine for where to send people and for how to use these resources. Anybody familiar with SC here in town? SC is one of the big managed care plans in town. They can get down to about $6,800 a year per patient and provide pretty good care. In these Medicare savings plans, you get to take that savings divided in half. Medicare gets half and you get half. SC doctors earn a lot of money when they can practice good value-based medicine. The fine line has always been, are you practicing good value-based medicine? Or are you a gatekeeper and keeping them from getting the services they need? And therein lies the rub. There's a lot of evidence that says if you do quality medicine, you can save Medicare a lot of money. And in new paradigms, you'll get paid for that. What you don't want to be is a gatekeeper, restricting care, not practicing evidence-based medicine. And there's a fine line there sometimes. Hospitals, you see, spends $1 to $4 roughly. They don't like this number. They're going to be hurt in the future. Post-acute care has gotten a lot of attention. This is the top number is all post-acute care, home health care, everything, nursing home. We've gone up from about $26 million in 2001 up to over $60 billion in 2012. That's a whole lot of money. And the heyday of pushing people out of the hospital happened before this, frankly. So we've been seeing more and more people go into post-acute long-term care, but not necessarily better metrics. That's getting Medicare's attention. If you look at the SNF line, which is this one right here, we've gone from about $12 billion up to about $30 billion. That's a lot of money. Nurse home operators are very happy with that. Their margin runs about 15%. Every $15 goes to a long-term care company, they make $15 potentially. Now they throw that money back in the building, they got to buy computers, they got to buy new equipment. Scrupulous operators. Bad operators don't buy a damn thing, and they pocket 15% of the money. There's little rules about this, and this has gotten OIG and other people's attention. They're not happy about this. One of the reasons that Medicare has been hesitant to give post-acute long-term care any more money for research, developing new models, they're telling their operators, you guys do it. You're making a 15% profit margin. You guys need to develop the new models. We don't want to put any more money in. And unfortunately, our E&M services haven't done any better. If you look back at all NIF services and charges, this is how much they spent in 2009, $1.6 billion in 2009. That's for E&M services. That's for you, me, podiatrists, ophthalmologists, any doctor that walks and bills Medicare Part B in the nursing home. That went up all the way up to $2.2 million, a 38% increase in charge over 4 years. If you look at the whole rest of the E&M world, radiologists, ophthalmology, podiatry, internal medicine in the office, it only went up 1.7%. We don't look good to Medicare right now. There's a lot of reasons for that. We are making more visits to people. We have much more nurse practitioners. And we're hopefully starting to keep people out of the hospital better. In the project we're running here, not through the university you're thinking of, actually Missouri University runs the rehospitalization grant. We've managed to reduce hospitalization for nursing homes about 25%. That's a wonderful thing. A pneumonia, in case you don't know, is $17,000 to Medicare. If you keep somebody out of the nursing home, if you treat somebody in the nursing home for pneumonia with IV fluids and IV antibiotics, you've saved Medicare $17,000. What do you get for that? Right now, a pat on the back, my best wishes. That's going to change in the future. But this money has got Medicare's attention. Everybody else has been staying stagnant. We're going up in costs. There's other fiscal factors affecting it. The number of people making visits actually is all attributable to 3 categories: nurse practitioners, physician assistants, and PM&R, and then psychiatry to a lesser extent. The number of doctor visits from internal medicine and family practice stayed flat. Now, and nurse practitioners have gone up from 12 to 30% of all visits. I love nurse practitioners. I love PAs. However, there's only a couple of articles. You look for where is the value. There's a few articles, the Evercare model everybody's familiar with, that show that you put nurse practitioners in a home, they save money, people are happy, everything's great. That hasn't been duplicated. There's not that many more articles out there. Auslander had a few articles. But unfortunately, Medicare is looking at the PAs and MPs and going, what are these visits doing? There are unfortunately some unscrupulous doctors that hire droves of NPs and PAs, make visits like crazy. They have quotas. You've got to see 20 people a day. And they don't care if they're sick or not. They walk through the home. The nurse sees the nurse practitioner and says, come over here and look at this cough. What would have happened a year ago? They would have assessed the cough themselves and called the doctor. Is that a value-based visit, or are you turning patients just because you happen to be there? We need to be careful of that. A presence in the building tends to mean more utilization of services. That's been shown over and over again. You look at the cost of health care in Minneapolis versus the cost of health care in Miami, it's double in Miami. If you look at rural versus urban, it's almost double. Availability of resources mean people come and use resources. We will have to be gatekeepers, but in the right way. Mrs. Jones, this isn't evidence-based medicine. With hypertension, you need to see me twice a year, not 5 times a year. We're going to have to be a little tough with patients saying this is what you really need. When you walk in a nurse home, you're going to have to tell the nurse. I did this last night. The nurse grabbed me and said, Bernadine over here is complaining of side pain. I'm not looking at you, assess it. I don't care if I'm in the building. It's your job to assess it. Look at the patient, take vital signs, examine the belly, and then tell me if I have to see the patient. I can't be a surrogate nurse. And therein lies the problem of having more practitioners going to a home. Be careful of what you see there. You may end up accidentally churning visits with the best of intents.
Yeah, I'm a nurse practitioner, and I used to go to nursing homes, and I would have my scheduled patients I would see, and they would know I'd be there Thursday morning, so they would call me, hey Matt, on another floor this patient, and so I would go see him and obviously bill for it, but there were times where it maybe wasn't necessary, but then there was times where I felt I probably prevented them from going to the hospital, so.
And it's a problem.
Yeah,
you're preventing some hospitalization, but at what expense?
So there hasn't been much data on how much savings,
At least in 2010 now, the data from 2010, I only showed you 2010. From then on, there's some evidence of cost savings, but it's not making up for the money we're spending yet. But hopefully that's investing in the system. And our rehospitalization project, the first 3 years were a wash. It's this last year we've gone gangbusters.
But I didn't feel that the staff abused it. I mean, they wouldn't just call me and say she's got sniffles or something like that.
But that's one home.
Well, I went to multiple homes.
Right. But it's a culture too.
I didn't feel like they ever abused that.
I support Matt. I think it's variable. Having worked in lots of homes, some homes are extraordinarily abusive,
right,
and others aren't. So I think it's very variable.
I'm just saying you need to be careful though, and just make certain not accusing anybody.
I would argue that I would prefer to see my advanced practice nurse in the nursing home than me most of the time. I think she does a better job, but she happens to be extraordinarily good. We know that.
No problems about that. And I don't mean to cast aspersions on the present model, except to say you need to show value. When you keep people out of the hospital that visit, it's worth it. There is no doubt. And Medicare isn't really auditing these visits so far because they want you, right now, they have this two-sided argument. They don't want you to make a lot of visits. On the other hand, make a lot of visits, keep them out of the hospital. If you keep people out of the hospital and have good numbers, they'll leave you alone. If you make a lot of visits and your rehospitalization numbers look bad, they're going to look at you twice. And your homes are going to know that soon. That metric is coming up on every radar, ACOs, every aspect of value-based medicine. Every home's going to know their number. It's going to be a nurse home compare. You can find out any home's rehospitalization.
Is that metric going to be by physician or provider or by home?
By everything soon.
Everything, yeah.
Yeah, we'll get to that in a moment. Managed care is one option. Optum is in town big time. They do a pretty good job, but it's one model. And it may not be for everybody. Basically, Medicare is not certain what we're doing. They're looking at us going, all right, and it's partly their fault. They've never invested in our infrastructure. EHR in my office practice, paid for. Nursing home, not a dime. Current systems don't address quality and cost well. What is a quality metric in a nursing home? We'll get to that, but good Lord. Is it a hemoglobin A1C of 8? Is that really what I want in a nursing home patient to judge quality? What blood pressure? 160 over 90 or 120 over 70 now with the latest articles? Who knows? Do they die with a smile on their face? I haven't invited a smileometer to come in the patient family smile on their face. There's a lot of alternative models coming up. We're going to discuss some of these. This is acronym city here. The one I didn't show was a doctor shaking with the acronym above. I'm overwhelmed, horribly, and scared of health information technology. OHSHIT.
That's good.
The new measures are quality metrics. We're going to be paid not in dollars, but in how we improve health care, improve population health, and increase cost of care. That's the three. If you can do these three things, you will win. And you'll do your patients well. Ideally, this is aligning our incentives with the patients and healthcare's incentives. There's six national priorities. Some of these may or may not apply to long-term care. It's been debated what our quality metrics should be. Anybody participating in PQRS, Physician Patient Quality Reporting System, right? They use quality metrics. It costs about $1 million to come up with a quality metric. It's not cheap. You have to have evidence behind it saying this really works. They're going to be translated soon into ECQMs that operate on your computer without you knowing it. In the future, your computer will abstract data from you, and it'll find out what your patient's hemoglobin A1C is, or with an advanced directives in place. You won't have to submit data, it will be done for you. Population health is poorly defined in long-term care. What population am I dealing with? There's a big difference if it's skilled patients versus Alzheimer's patients versus end-stage renal disease patients. So we're going to have to define our populations. Costs are actuarially based, which poses some problems. For the most part, they exclude pharmacy and DME costs, but not always in some of these models. It's a question, should you exclude pharmacy costs? In certain populations, probably, and others, probably not. In a dementia patient population, you can make an argument to include pharmacy costs. Why should it be that much different? Oncology patients, who knows? PCRIS is occurring now. The 2% penalty going to be increased, and all this is going to fade to the new MIPS model. But you've got 284 measures theoretically. And to look at them, we have 39 measures that are real world, we'll show you some, and 7 group measures that could apply. Of those measures, actually only dementia is the only good one. It gets confusing because you're supposed to report on 9 measures that span 3 quality domains on 50% of all Part B patients, or a group measure. After a while, you start looking at this and get blurry-eyed. And this is why you have practice administrators to help you manage this stuff. You should know the basics, however. The value-based modifier system that's now in place looks at both cost and quality. You have to participate in PQRS so you can measure quality. The costs are based on all non-pharmacy charges. It started according to group size. 2015, groups of 100. 2016, groups of 10 or more. 2017, individuals. However, with the new bill being passed, everything's being transferred to MIPS, we'll discuss in 2018, which is a kinder and gentler value-based medicine system. They tier it like this. In the top, you have your quality metrics up here, those 6 domains. You get a composite of care quality score based on how you do relative to other people. And nobody scores perfect. Things as simple as influenza vaccination. People don't hit 100%, so you're compared to your peers. And many of these metrics, we do pretty good in long-term care. If we look at vaccinations, we clean house. One of the quality metrics is not culturing a surface wound, which hopefully nobody does. It's worthless. We can clean house on it. So we don't do too bad on quality metrics up here. What we get hurt on is per capita costs. If you're in a SNF, how much money you're spending compared to an office setting? A whole lot. That has been taken care of, but that was a real problem for a while. In addition to total per capita costs, they pull out separate conditions, the big ones, CHF, COPD, diabetes, mellitus, look at those patients separately. They come up with this metric to compare you to your peers and tell you, compared to your peers, you're in the 40th percentile, 60th percentile. The whole thing is grouped into this mess where you have quality on one side, cost on another. If you're in the middle, you get no payment adjustment. If you're where you would like to be with high quality and low cost, you get a 4% bonus. If you're down here where you don't want to be, low quality and high cost, they take away 4%. The people that are sickest automatically give you 1% benefit. This is all going to go away, so don't spend too much time with this, especially because, on the next slide, almost everybody was in the middle. Average quality, average cost. This is preliminary. This goes 2012. This is sort of the experimental phase. This was for everybody, all physicians, cardiologists, GI, internists. We work with a group called Visions Group. Visions is the nursing home administrators that run long-term care physician practices. Big groups, 100 or more doctors in some parts of the country. They looked at their data, and big surprise, they were all high cost because of SNF. When you deal with a SNF patient, you're spending more than $10,500 a year when you annualize it. You can spend that in a month easily. So we were being killed on that. We did approach Medicare, and as I'll tell you, we hopefully got that fixed once and for all. QRUR reports is what you're going to get in the future. Quality Resource and Utilization Report. You'll get it by department. My understanding in the university setting, your department will get a QRUR report, and you'll know how the whole department did compared to other people. It's not a fun report. It goes through pages and pages and pages. You have to have a practice administrator run the numbers for you. Basically, when you have more PCPs in a practice, you do bad. Because of the nature of quality metrics, it's easy for cardiologists, urologists, and people to score very well. A urologist getting credit for checking a PSA, how ludicrous. A cardiologist getting credit for checking a lipid, how ludicrous. Whether they needed to or not, they got credit. It's harder for geriatrics and PCP to meet some of these measures because we often get the recalcitrant patients. The diabetic who won't do anything and their hemoglobin A1C runs 9, you get killed on. Costs go up with age and comorbidity, as shown in geriatrics, we get that. They try and risk adjust this, but it doesn't work well. Risk adjustment tends to not work well at either end of the spectrum. I've had a few people in the office setting that never see me in a year. They have no medical problems. They take no medicines. They're 70-year-olds and healthy in the community. I have to drag them in. And they spend no money. How can you risk adjust that? I have some patients that come in way too often, don't take care of their health, run up big bills. How can you risk adjust that adequately? So the opposite end of the spectrum cause the big problems. Post-acute patients are the sickest. They're in the top 5% of expenditures uniformly. A group from AMDA, including myself, did talk to Medicare. They did believe us, and they did actually, in what's called the final rule, comes out every November. What is Medicare going to do next year? They're pulling out SNF as a separate comparator. Right now, your NIF patients should be compared with your office patients, assisted living, everything else. SNF is being pulled out, and they're going to run that data separately. Understanding finally those people are more hospital-like patients. SNF is called a facility for a reason. Whereas SNF, the chronic care patients, you can probably do good on. When you think about it, your NIF patients, the demented people, do they spend $10,500 a year on Medicare costs? No. Nowhere near that. If you get a nice, stable nurse home with calm patients, and you can take good care of that home, you can save Medicare a lot of money, and you'll make money yourself, in theory, under these models. We've had some thoughts that actually may discourage people from doing complicated NIF patients. There could be some cherry picking. I only want the patients with no problems. I only want the patients that don't have a med list of 5 or less. There's any number of criteria which you can start cherry picking patients, unfortunately. There's always somebody out there gaming the system. When you look at quality measures in PQRS, there's a limited number. I mentioned 46 quality metrics. Some of them can be contrary to best practices. Diabetes, actually, the quality metrics, the hemoglobin A1C less than 9. It's not hard to meet. But there's other metrics that aren't so good, like lipid control and people with coronary disease. What am I supposed to do with a 95-year-old who has some distant history of heart disease 20 years ago, who's demented in a nurse home, is losing weight, and their cardiologist has them on a statin, and I'm going to take them off and get dinged for it?
I just put down that they refused.
There are exclusion criteria, and actually for many of them, a lot of the exclusion criteria start at age 75. Some of these metrics don't apply to certain age groups. And that's one of the problems in a nurse home. We have trouble by age finding people that have a quality metric you can even use. This is actually, believe it or not, there were a lot worse. You may argue about coronary disease and antiplatelet therapy, but these are the ones that are appropriate for long-term care. 81 milligrams of aspirin in somebody with coronary disease in a nurse home is not unheard of. That's relatively safe. Beta blocker if they have a prior MI or LV systolic function. That's debatable, but often doable. Advanced care planning, no problem. Influenza vaccination, no problem. Anticoagulation therapy for AFib flood with some exceptions, normally not a problem. Preventative care, screening for high blood pressure and following up is a quality metric. Just checking the blood pressure and saying, I'm going to do something about it, is a quality metric. You don't have to get into goal, you just say, I'm going to do something about it, check a box. Fall risk assessment is done for us in long-term care, pretty easy. Chronic wound care, those are all very easy quality metrics. So you can score high in these systems. It's not a problem. Now, whether it really indicates the best of care in the world of long-term care, we can debate.
Chuck, do you mind if I ask?
Yeah.
So, were you and AMDA and others instrumental in getting some of those?
Those you actually pick. National Quality Forum gives them to you.
No, I mean,
We put through the dementia. With AGS, we put through the dementia measure. We're instrumental in that.
I mean, the wound and the falls.
They actually, those are already in there, thank God.
So
We don't have $1 million to put forth the quality metric. In the new legislation, there's theories of money to put forward quality metrics, but you got to get the evidence. You got to go to the National Quality Forum. You go to meetings. It's a bunch of money. So some of these have already been pushed through AGS primarily.
Okay.
You're telling me they're going to use the Sprint study that every one of our patients has to have a blood pressure of 120, despite the fact that they all got renal failure and they stopped the study early.
Well,
I mean, this is,
No, but that's the problem with data. Does it apply to your group? And that's why we have the quality metrics all the time in our age population, what represents quality.
and as you know, I spend 90% of my time in the nursing home getting rid of medicine, but they're not giving me any credit for that.
Well, that's been actually argued as a quality metric. Do you want 9 or more medicines as a quality metric to be a thing? In the NIF side, I'd say yes. The SNF side, I'd have some problems, because I don't have enough time to control that.
I'd be happy also down at an average of 7, so, you know.
Yeah. The group files are easy to do. Dementia, there's some quick fixes that are going to be done this year, but that's an easy one to do. In a nursing home setting, chronic care population, that's probably the better metric to do. Now, frankly, for a lot of you, this is all done by practice administrators in the background, but they'll be watching what you check, and they'll be in the background going, doctor, please document this, sort of like your hospital patients. Please put down acute respiratory failure with hypoxia and hypercapnia to get more money. So you'll have auditors trailing you around telling you to make sure you document. What are best practice QMs? Medicare is interested in this. They actually require quality metrics as they become less appropriate. They don't want low-lying fruit. If everybody does it, it's not a quality metric. It's a standard of care. They want evidence-based medicine, and that's where we have trouble. What evidence do you want me to look at in the geriatric population or by populations? There should be an identified gap or need. Where are patients suffering and how can we do better? Dental care in nursing homes. Do you want that as a quality metric? It's a gap. Yeah, I sort of go, ooh, do I want that one? I do and I don't. I want a lot of exclusion criteria. ECQMs actually have the ability, it's not a checkbox. They in theory can be a complicated routine. So you can have ECQM that says dental care, but exclude hospice, exclude people with no teeth. You can really have many branch trees you would never able to do in a paper model. So theoretically, with these electronic quality metrics, you can get some pretty interesting quality metrics with a lot of branch points. Improvement should be achievable, thank goodness. I can't make people live forever. Death is not a quality metric. And quality metrics should be retired as they get older. For us, we have several problems. We want to make sure that we have appropriate comparator groups for cost and quality metrics. Cost, it looks like we have some of that argument. We don't know how they're going to compare SNF yet. It's probably going to be SNF to SNF patients. But even there, are all SNFs equal? When a home specializes in hip and joint repair, that's low-lying fruit. Those people leave in 5 to 7 to 10 days at the most, compared to a complicated CSF, pneumonia, end-stage renal patient that's going to be there for 2 weeks and then die off. We don't have any incentives to get health information technology. It's a travesty that the home has all this MDS data that doesn't automatically dump into our system. Medicare has a lot of interest, as we talk about integrating nursing home quality metrics with us. Shouldn't we at least have some quality metrics that look a lot alike? Should I be responsible for pressure ulcers? Kindred's not doing that. They have an informal system where they're looking at their doctors and comparing them. Dr. Ray has this many pressure ulcers, this many people in pain, this many people with late loss ADLs. They actually take all the MDS data out and assign it to the doctor and compare the doctors. It's preliminary. They're trying to see if this makes sense. Is it this patient population? Is it really doctors' ability to control this data? What can a doctor do if you've got a bad nurse home administrator or a bad coach to the home that doesn't want to make improvement? Would having joint measures just make bad nurse homes get worse and good nurse homes get better or look better? We need to have seamless integration with pharmacy. Pharmacy is sort of this no man's land if it's not an institutional pharmacy, but it's not Walgreens. It's very hard to e-prescribe in a nurse home meaningfully now. Can we get really meaningful quality measures that have a lot of those exclusion criteria? One way around all this is to be a specialty. Right now, we're not a specialty. A specialty gets a lot of special considerations in these models. But if you're a specialty, are you that all the time? Are you an internist part of the time, the geriatrician part of the time? Over here, what are you? Some of these problems are addressed in the merit-based performance performance model. It consolidates everything. Right now, you've got penalties for EHR, you've got penalties for meaningful use of value-based medicine. It gives us these 4 lovely domains to look at. The quality score, we're 30 points overall. Cost score, 30 points. Meaningful use compliance, you automatically get 25 points for meaningful use criteria. And the fun was clinical practice improvement, 15 points. They want to see that you're trying to become a better doctor and a better healthcare system. That's been a point of contention. They have 6 domains of clinical practice improvement shown here. Some of these aren't so hard. Expanded practice access. These are all meant for an outpatient world. They want a doctor to have office hours till 7 o'clock. One of my office hours in a nurse home? Never. I'm always on call. They call me day and night. I go on the weekends, I go to night. This is no problem for us. They get our advice all the time. Population management. We have the potential to do this with more electronic records. I'd love to have more data in my nurse homes. I want to know how I'm doing with my diabetics. I want to know best practices. But give me the information technology to do it. Care coordination. We do a fair job of that. Not necessarily in transitions to care, but there's opportunity to improve things there. Beneficiary engagement. I think we probably engage our beneficiaries more than most other sites of service. For the most part, we have our patients and families together talking about what's going on. Patient safety and practice assessment. That's pretty well the nurse home's domain. I don't know how much we do of that, but can we make our patients safer where they're living? And then participation in alternative practice models we'll talk about in a moment. So in terms of MIPS, worrying about this, it's probably not a big deal. You're going to hear some about this, and people are screaming, the AMA screaming, this gets too burdensome. For our world, I don't think it's burdensome. I think it's part of quality assessment. And in fact, one of the keys AMA is making is cooperative projects ought to account for all this. If a doctor's involved in a cooperative project, that's all of this in one piece. Payments are a little different. In the value-based medicine, that safe middle, I showed you 80% of people are average cost, average care. Not with this. They have a percentile. Anything above or below that gets paid more or less. It's a razor edge, not a big middle. And CMS gets to set that. They don't have to set it at the 50th percentile. They can say we're making the average payment at 70th percentile. Only 30% of people get a benefit. The other 30% of doctors take a hit. So 1 point up or down gives you problems. Yes?
Look, I have a problem with the math of this, the 50th percentile. If everybody's getting better, the 50th percentile is also getting better, but there's no description of the good or the best.
Right. That's the problem with the system. There's no threshold.
And what happens is that the variability, whether it's real or it's paper shuffling, there ends up being no variability, which was the real definition of quality in the old days with Toyota.
Right.
You got 0.2% variability, and it was the variability that determined the quality. This is totally different.
It can stifle innovation, theoretically. It's a double-edged sword. I mean, it's difficult to say how this is going to pan out. But Secretary of Health has a lot of leeway in administering this. One of the reasons they made that threshold go up and down was to see what was the right thing. They may decide that thresholds should be low down and everybody should get a bonus that's in the top 60%. You just don't know where they're going to land it. The penalties get a lot more. 2022 it could be a 9% penalty. So instead of $100, you can get paid $109 or $91. That's a fair swing that gets people's attention when you start doing that. And the fun thing, all this is reported on Physician Compare website. Your patients can go in and find out what a good or schmucky doctor you are.
Doesn't this further encourage cherry picking?
Yes, absolutely. And that's the trouble. How do you get around cherry picking? In theory, your risk adjustment takes care of that. If you cherry pick, your risk adjustment goes down so bad, you have to perform so good, you'll never get there. If risk adjustment works right, the sick patients are worth so much money you want to take them on because you get so much more money for them. But can they make that risk adjustment right? I'm not a risk adjustment person. We have people at AMDA that are, and they're advocating the current system doesn't work well. The PACE system plus another frailty model together seem to work better. There's also patient expectations that's a problem. Patient family expectations, Medicare doesn't want to hear this, do play a role in what we do. And we're supposed to control that. I can't always control that. How many people we have on hospice, you enroll in hospice and they die 2 days later? I didn't do my job, frankly. But I tried my damnedest. And I can't make people switch to hospice status when they clearly were benefit much earlier in life. Alternative practice models is another way to get around all this. The idea was, all right, you don't like what Medicare gives you, make your own model, and we'll look at it. And some of them are already out there. There's alternative practice models, for example, for prostate cancer. A bundled model is an example of the type of one. Bundled models now for hip and knee replacements are happening, where there's one set fee, this is what you get, spend it any way you want, you get left with the bag. The hospitals get that bag right now in the bundled model. They're going to get all the dollars for hip replacement. They'll come to your nursing home, they have to pay you the money you charge. And down the road, if they've spent more, they lose money. So they'll want to use homes that provide high value, that get people out the door quicker, without them bouncing back and costing the system more money. So if you do shoddy care, you cost the system money. If you give good care and keep them out, you do better. So for nursing homes, it puts us in a unique role with all these models, bundled ACO. You not only have to look at what you're getting coming in the door, when they leave, you have to make sure they're getting good care. Because if you have a lovely nurse home that does a good hip pneumonia, you send them home and there's a bad fall from the home health care company, you're going to get dinged. Because the hospital thinks you did a bad job of discharging. So your nurse home is going to have to become both a forward and backward looking facility that looks, how can I make sure the whole continuity works? The idea is right, it shuts down silos, which has been a problem all along. It's no longer they leave your door, it's like, goodbye, don't come back. It's like, for God's sakes, don't come back, please. All take risks. All these models, somebody has to take some risk of financial loss. And you buy reinsurance in all these models. Yes, you don't go to the poorhouse with a barrel, You buy reinsurance so it's not catastrophic. If you don't like any of this, you can just retire early. For the next 5 years, the penalties won't get that bad. You can just say lump it. I know a doctor in nursing that does that. Dr. A. Well, I'm in that boat. I could retire in 5 years and just lump it all. I joke with my patients, I recently changed where I'm practicing. I said, I was just going to do this, or it's going to be mow my lawn for a cold, little illness, give me a chicken, big illness, give me a pig. We'll call it even. I'll just go back to bartering. Accountable care organizations. Does St. Louis have an accountable care organization?
Not yet.
Okay.
It's coming.
Yeah, and it's probably a good practice model, although your ACO sort of looks like a value-based medicine system. They use some of the same parameters. It's just on a smaller scale you can manipulate easier and have a little more room to go to somebody above you and go, wait a minute, we need to fix this. Right now there's 4 million beneficiaries as of a year and a half ago. That's 14% of all beneficiaries. You don't want to be a contracted vendor. If you don't participate in ACO, if they just say, we're going to give you this money, this is all you get, that's not a good thing. You've got to have some latitude for arguing with them. If you get $5,000 for the most complicated patient, that may sound like a lot of money, but they're going to give you the worst cases in the world that nobody else will take when you're a contracted vendor. ACOs have some pros and cons. The original pioneers, a lot of them have dropped out because they had a lot of problems. The basic problem was you were paid to make improvements, which was a wrong thing to do. So if you were a high expenditure, let's say you spent $12,000 per beneficiary per year, you dropped that to $11,000, you saved $1,000, you look good. But you were still way above the median. But if you already came in at $7,000, you only saved $500 to $6,500, you looked half as good, but you were saving money to start with. It didn't reward people that were already practicing good medicine. It rewarded only the absolute improvement, which is wrong. You've got to look at where you are, your benchmark, and where you're going. Some of the other models are helping that. The advanced payment helps with upfront costs of an ACO. The next gen program, I'll talk in one of the slides, it's a better system. I think it's the one that most ACOs will be going towards. How this works with long-term care isn't understood really well. A lot of ACOs don't own the home. They farm it out. They use a star rating system to figure out whether they use their services. You want to have at least a 3-star rating to your home. 1 or 2 stars, you will not use it. Some 3-star homes get put on probation. If you get a G citation, they look at you twice. You have to have metrics out there that are in for it. You have to have your rehospitalization data. They want to know how you do on pain control, things like this. National companies are looking at that data a lot and providing it. The trend will be to getting, right now ACOs operate like everybody else. You have to give the patient a list of homes. Here's the homes in the greater St. Louis area, you can go to any of them. Well, they want to say, don't go to this home, they charge a lot of money, we pay for it. They're going to be allowed to guide people based on hard data. They'll be able to say, nurse home A has rehospitalization rate of 15%. Nurse home U pick has a rehospitalization rate of 30%. Which one would you like to go to? The choice will become obvious. Rehospitalization and star rating are the two things you have to know right now. You should know that as a medical director's position what your home is doing. The other option is just get out of the SNF business and do all NIF. There's nothing wrong with that. In states where this has gotten very popular, homes have literally closed literally within a week because your SNF business just dried up to nothing. They're just totally excluded.
Do you know of any ACOs that are actually buying facilities and trying to do it by themselves?
Some on the East Coast contract, but most of them do it from an arm's distance. LTACs right now are just, they smell bad. They cost a lot of money. They've not been proven to be superior. And LTACs are going to take a big hit on us. They just charge way too much money for what value. And we get down to condition-specific payment, which is the way of the future. It's not going to matter where you go. It's going to be, you have this hip fracture, this characteristics, this is how much we pay. You have this similar, this characteristics, this is how much we pay. We don't care where you go. When you run out of the money, somebody's not holding the bag. Your ACO, your hospital, whatever.
How about ACOs and home care? Same deal?
Same deal.
Looking at stars and
Right, they'll pick
Not-
these.
not trying to run their own.
With good ratings, yeah. You can get people out. Which all of us are now living in two worlds. On the one hand, no matter what we run, you want to have a fee-for-service and that has long lengths of stay, makes lots of money, and you have managed care plans, you want to get them in out quick.
right.
And we're going to merge in the middle somewhere with this, hopefully with the best practice. Right now, there's a problem with attribution. You're assigned to an ACO and a doctor based on who makes the plurality of visits in that year. Whoever makes the most visits, December 31st, thing, that's your patient. That was a problem in a nurse home originally, because in the SNF, a patient may have seen their doctor 5 times that year, they came to your SNF, you saw them 6 times, bingo, your patient. December 31st, all that cost, all those hospitalizations are all of a sudden yours. You're getting more of it screwed, basically. That's one of the reasons we want to get SNF taken out of the primary basket, and it will be, thank goodness. So that won't happen to you in the future. That was happening to some of these big groups. They look horrible at their expenditures because they've got all the suspense throughout the entire year. How they're going to judge this is up in the air. In the NIF, it's still whoever makes the plurality of visits. Your NIF patients are going to be your ACO patients, and that's not a problem. You should be able to manage your NIF patients pretty cost-effectively and humanistically. You keep those people in nursing is a good thing. I've been doing that rehospitalization project for 4 years. Not a single lawsuit. That's just totally bogus. Families are ecstatic when I keep them on there with IV fluids, IV antibiotics. They don't go to the hospital with delirious. They don't sit in an ER stretcher for 5 hours when you do this ulcer. I get an IV antibiotic going within an hour. They go to the hospital. I'm lucky to get an IV antibiotic starting in 10 hours. It's just a much more humane way. Exclusivity is another problem. In theory, you can only belong to one ACO as a primary care doctor. Now, in a NIF patient, that's not so hard. You're probably going to be St. Louis U ACO, and your patients will belong to your ACO. If they come from another ACO, you get to switch. Not a big deal. In the NIF world, in the SNF world, that was a problem. Life Care probably got people from here, but they probably got patients from other systems. And when they did, what happened? Well, if they're another ACO, I have to see my ACO doctor. They can't see you. Medicare is in theory addressing this. It's not really hammered out, but most likely if you work in a SNF, you'll be able to see other people's ACO patients. They've sort of been turning a blind eye to this for the most part. Next generation ACO is going to be coming soon.
You have to get referrals, because I had a patient come from one in the skilled nursing, and I just took care of her for like 8 weeks, and we can't get the doctor to give us a referral.
Yes.
So I haven't gotten paid yet for it, because the doctor doesn't seem to understand. I mean, you didn't come into my nursing home.
Yes.
So we're having trouble. I think I need to like call him and explain it or something, but he won't. Our secretaries call our biller person multiple times, and he won't give a referral.
Yeah.
I mean, it's already done, and she's already gone.
Right, and that's a problem. You have to get referrals.
And then they were having their own nurse come in and write in the chart, and it was really strange. I didn't really understand what was going on.
That's the problem with some of these Medicare Advantage plans also. They'll send in...
Who knows?
Who knows what. You know, there's still the rule that, I don't care whether you believe it or not, but the initial history physical has to be done by an MD or DO in a nurse home, period. And some of the plans that are practitioners say, we're Medicare Advantage plan, you don't have to do that. No. But you can care how you do it, but there has to be a doctor make that initial care plan, because that patient is so sick, they came from the hospital, it takes a doctor to do this.
But obviously, they couldn't like follow the patient in the nursing home. They didn't have privileges in the nursing home.
Right.
So they were just coming in for social visits. I assumed they knew the patient, but the nurse was like, "Oh no, I'm just sent out by the company." Sort of thing.
Would it be unethical to say, send it back to the hospital?
You can do that, yeah, because they
It won't
basically
help
send
your
it
nursing
back. You can report it to the State Board of Healing Arts, which I did in one case, patient abandonment. When they don't see their patient, they're abandoning their patients.
But
And
your
you have to
nursing
see-
home doesn't want that because they're getting paid. So you have to recognize
Yep.
that this defaults to the medical director, whether you like it or not.
Right.
And you just don't get paid. That's why you're a medical director. You hope they're giving you enough money for those patients because somebody's got to do it.
Maybe reporting them and saying, this doctor's not giving us a referral.
Yeah, theoretically, I've heard these.
Have you heard of that happening to us? It happens to Dr. Little sometimes too. It happens to us.
Yeah.
You know, they always are calling. Yeah.
In theory, you could have them sign advance beneficiary notes, an ABM saying the services are covered, you have to pay for it. The patient gets in a high course and then calls the doctor and says, I want my damn referral.
Yeah, that's what I do. You get the patient to call the doctor,
Right, because in theory, somebody has to pay you.
or the family.
Right, and then it's the Office of Beneficiary, what is it? There is an office of Medicare that looks out for the patient beneficiary. And it's actually a medical director, Amanda, that
But you have to give, they have to give up their patients. So all they have to say, if it's an ACO, is they're coming in and seeing the patient, and they're doing like so many doctors do, keep the records. You know, if somebody goes out, they keep the records in their office, and you never see the records. So basically, it's very difficult. I mean, you're stuck with those patients.
well, this idea of staff privileges, and SNF, this is something Medicare is aware of.
But if you demand staff privileges from a ACO or an Advantage program in the old, that means the Advantage program will no longer put those patients in your nursing home, and you won't be the medical director much longer. So in fact, if you finish up giving these people privileges, because they all have sufficient criteria to have privileges, the criteria they don't have is they don't like to work. But that's another one.
If you don't visit the patient, then you can report it to the state survey agency and the survey home.
You can still finish up. I mean, the nursing home is much more interested in getting paid. I mean, let's face it, with a few exceptions, that's true.
But you need to work that out in your contract negotiations, and the administrator should be wise enough to know not making visits runs the risk of rehospitalization. And you're there for a reason. If they don't believe it, the state survey agency is going to get a little tired of people not making visits and citing the home for not making time.
I mean, I understand that, but I also understand the reality base
Yeah.
that at least some of us have had to deal with.
Well, hopefully you can make quality visits and make a difference, so I want you to make visits. I mean, it doesn't always work. Some people get better no matter what we do, unfortunately. ACOs look at these measures, basically length of stay, quality metric star we talked about. Special programs, sometimes I like their special program. A CHF program is a real winner these days. Proximity, obviously. They make save money sending them out to DeSoto, but who wants to go out to DeSoto? Again, most of them are downsized. Missouri Baptist Hospital right now refers to about 102 nursing homes in the time of the year. Their ACO is looking to be downsized to 12 to 14 homes. I'm a math director at Delmar Gardens. I'm working very hard to make sure Delmar Gardens is one of them.
Are they clearly looking at readmission because we're now getting tons of patients at Maryland Heights from Missouri Baptist. And,
They do.
So we must probably stay in the 12 to 14, even though we have nothing to do with them other than that our readmissions are low.
Yeah. This is where hospitals, this is where nursing homes fall. If you want to know where your nursing home is, there's homes, 0.6% of homes have over 50% readmission rate. They take the sickest patients, they got the weakest staff I've ever seen.
Wow.
On the other hand, there's homes, 3.6% of homes have less than 20%. If you look at SNF patients, one out of 5 SNF patients gets rehospitalized within 30 days. For all NIF patients, it's 25%. So they have to get rehospitalized more quickly, shall we say. Hospitalizations cost a lot of money, $14.3 billion in 2011 dollars. They estimate, and you can blame Joe Ausland for this number, I don't believe it, 40 to 60% are avoidable. I think it's probably more like a third to 40%. on a good day. But if you look at the ones that are due to 4 common conditions, basically infections and volume and fluid status problems. I mean, think about it, we can treat a lot of this there if we find it early enough. You can't treat it when they're septic. And somebody missed a change of condition for 3 days because they weren't eating. When you find those condition changes early, you treat it early and jump in there with both feet, you can prevent a lot of hospitalizations. Looking at key quality metrics, the ones ACOs everybody's going to be looking at: pain, pressure, ulcers, antipsychotics. Secondarily, look at ADL and loss. They'll want to see some sort of quality process. Do you look at your physicians to know who's doing well and who doesn't? They're going to be looking at that soon enough. They can drill down that data from Medicare. If nothing else, by 2018, they'll know who's a high re-hospitalizer and who isn't. And yes, they will start giving people referral people who don't hospitalize as much. They want to see your length of stay and percent return to the community. If your length of stay is low, but nobody returns to the community, all bounce back, who cares? You have to balance a good length of stay versus, yes, we send them out and it's durable. They don't bounce back. They don't go back to the hospital or us. Some 3 areas where you may want to look at for specialized programs: CHF, COPD, orthopedic programs. Delmar Gardens Chesterfield piloted program on CHF, and it really came down to accurate weights every day. That was harder to do in nursing than you can imagine. If you work there, you know how hard it is. But they went 2 months without a single rehospitalization on CHF by simply getting Lasix every day based on percent off dry weight. It was that simple. CHF program, COPD program is a little harder, but can you give timely nebulized treatments, changing conditions, get chest x-rays, labs in a timely fashion? Orthopedic surgery is a low-lying fruit, frankly. Those people, unless they're complicated, should be out the door quick, and they shouldn't have complications. Do you integrate specialists from the hospital program? Delmar Gardens Chesterfield actually got St. Luke's cardiology involved. God forbid they actually got a cardiologist that came to saw patients.
To the nursing home?
Yes.
I don't believe it.
Yes. It's right down the road.
And then admissions went up because they looked around that.
Well,
All the
that was your fault.
restarted.
I'm just kidding.
But can you do that? If you're home in proximity enough where you can convince a specialist, look, it's 5 minutes away, walk over there, see 3 people in half an hour, that's how long it takes them to make visits, and make more money. I mean, it should be a win-win situation.
I can see most major hospitals building a nursing facility right next to them because they can then control those readmissions.
Absolutely.
It's like we used to have Bethesda, we saw them and they never got readmitted because it was like treating them in the hospital.
Exactly.
Wonderful, right?
And what can your nurse home ramp up to basically take SNF patients on what amounts to a SNF unit? Can you run them in the hospital in your unit safely and effectively? Hospitalists are coming into nurse homes a lot. Pros and cons. Some of the better companies actually realize it's a different set of competencies. And what I won't mention is actually had an initiative to take their hospitalists and retrain them to work in a nurse home and do it right. I have no problems with hospitalists walking the door to treat SNF patients and they know the systems, don't raise a ruckus because they ain't get a stat CBC in an hour. It doesn't work that way. Learn my system, learn the rules, then we'll work together. And then adequate nurse training. It's getting tougher to find good nurses. There's a shortage of them. Just like with doctors, old ones are leaving their experience. You get nurses out of school, they think this is going to be an assisted living with people in rocking chairs. No. These are sick people that get catastrophically ill quick and don't tell you because they're demented. Alternative practice models are usually specially bundled care. Andrew's looking at some of them. A dementia model makes a lot of sense. Can you take dementia people without complicating medical conditions? The tough one's going to be dementia people with a lot of history of psychiatric disease. Those will cost money. And how do you define those groups and then put it into a payment model where you take risk? Actuarially, you look at your numbers. We used to spend $6,000 a year on dementia people on average. So we dropped that to $5,500 to still provide quality care by putting in special programs to treat these people in the right way. Can we get rid of all the Nepazole? I said that for you. Pneumonia infection models, CHF and hydration models when people come out of the hospital. Can we have these models whereby we take a bundled fee for the home and ourselves? The AMA is really interested, and so is CMS, in combined psychiatric medical models. Those are the most widely divergent patients in cost models. Some stay at a hospital, some go in the hospital every day. And how can you bundle that in a model where you provide good care? I don't know how many are familiar. Abbott Ambulance has a program in North County where they're providing primary care for frequent flyers. People call the ambulance every other day.
They just take them to the primary care doctor's office?
No, they're the primary care. They have a nurse practitioner on board that provides primary care. It was an innovative model. Instead of going to the hospital and spending all this money, let's just treat them at home.
Yeah.
It's an expensive taxi cab, but it saves the system a lot of money.
It's really sad.
Yeah.
Just
But-
overall, no, I know what happened.
Yeah.
I know.
Well, telemedicine in the future, can you give this person access to a television screen? My work is to have Dr. Oz do that. Let's give him a real job.
High-tech home care.
Thank you.
So
Trying to nurse them.
APM Hurdles, it's not easy to get APM, it takes a lot of money. There's certain criteria you have to meet that are getting more and more stringent. You can't just put this together and say, go to Medicare and say, give me $10,000, I'm going to take care of this group of patients every year. There's a lot of quality metrics, design things you have to show. There are grants available, theoretically, that AMD is going to be trying to get to look at some of these models of care. Hopefully some academic centers will too. Medicare more and more is looking at condition-specific instead of site-specific disease management. We talked about a dementia model, but they've told us, well, why dementia in a nurse home? Why not dementia at home, assisted living in a nurse home? We don't care where they live. We want to make a payment based no matter where they live, based on comorbidities. And maybe that makes sense, but that gets a lot harder to do. Do certain aspects of the disease predict hospitalization, or is it beyond that that we can't control?
Start with the caregivers. I don't want that one.
In a nursing home, you have to coordinate all this with the facility. It's fine for me to say, I'm going to keep my patients in the nursing home and provide IV antibiotics, IV fluids. What does the nurse home say? Doctor, you're killing me. Those people used to go to the hospital, they would come back and get a Medicare Part A stay. I'd get the bed hold, but I'm taking care of them. And we get all this extra money. You're keeping me here and killing us because now we have to get none of that money and we provide them services at no fee. Part 2 of our rehospitalization project actually involves a facility fee. They get a per day fee to keep them in the nursing home. The doctor will get a hospital level charge for seeing in the nursing home day 1 or day 2 if it isn't 40 hours. And you get an ACP level charge for talking with the family about directions. This is where we're going. So when you save $17,000, for God's sake, there's something in the facility, the doctor. So there's an incentive to do it instead of a disincentive, which is what the system currently has in place. Bundle payment models are all over, and frankly, they're now everywhere because, in theory, all hip and knee surgeries are going to be in a bundled model payment for almost every hospital this coming year. There's different models. We're going to run out of time, so the important thing to know is there's 2 models that affect us, model 2 and 3. One basically looks at the hospital plus a post-acute period. One looks at post-acute only. Medicare is interested in model 2. They want to bundle everything with the hospital, which makes some sense when you think about it. The trouble is who drives the sentence, the hospital. No offense, I don't always trust the hospital to figure out who gets paid what, in a nutshell. So there has to be some fair and equitable payment. Right now, under bundled models, the hospitals hold the bag. If money's lost or gained, they get it. You're paid fee for service. But is that good or bad? Is there an incentive to use just cheap homes and doctors to get them out quicker? They're really giving them quality. And what constitutes quality in a complicated patient? You know, a 6-year-old with 1 elective hip replacement is a piece of cake. Anybody can do that. They can go home most of the times now. There's a lot of things that affect bundle payment models. What's your definition of a chronic care model? How you define it? What conditions are most appropriate? What services you combine? If they have a complication, you throw that out to keep it in. Who gets attributed to the patient? Who's at risk? Who's not at risk? Who just gets paid fee for service? How do you influence the provider to have interest in this and do all this when they're taking risk? And what quality metrics are really the most appropriate thing? Is it home with a smile on your face within a month with no rehospitalizations? That's one quality metric. Is that the only one? There's various bundles they have. They're starting with major hip because that's the low-lying fruit. They're actually interested right now in stroke as another bundled model. Stroke can be very expensive and rarely dealt with. What's the best place for a stroke patient to rehab, what characteristics would predict going to home, what would predict not. You can define them within 48 hours and figure out where they go. Basically, every condition you can imagine has potential to be bundled if you're brave enough and have a system big enough to try and bundle and accept risk. They're trying to do more bundling where it shifts risk from the institution to the provider. There's some large physician groups that are going to be taking risk under some of these models. You have to be a pretty big physician group to take this kind of risk. You could really be left holding a bag. Anytime you put somebody in a SNF or LTAC, it's going to be higher costs, so they're going to want you to prove what you're really doing. Anytime you can go to home health care, it's better. We do influence utilization patterns, there's no doubt, but we tell the patient up front going into something. I had an 85-year-old with a hip fracture go home in 40 hours, and his wife took care of him. I'm like, do you think this is going to work? They were all on board. I was shocked. Yeah, we don't want to go to nursing home. They're bad places. We want to go home. We got family coming in. Medicare doesn't reward those people. They should. How can you get people to buy into this? They're looking for the top 10% of formers in a well-managed model. That's where they want. That's where their goal is. I think that's really lofty. Most of us are going to be well down towards the bottom. On all these models, Medicare takes about 3% of savings and gives 97% out, so they're automatically assuming you're saving 3%. The rest of the savings get split with you. If you're a big company and can save $2,000 per patient per year, that's a lot of money for your healthcare system. For academic centers, I'm interested to see how they manage this. No offense to academic centers, you get sick people. Sometimes you're high utilizers. And sometimes people come to you with horrible conditions nobody else fixed, so you're going to be high utilizers. How do you drive that cost down? How do you get a model that's going to say, I have these really sick people, nobody else will take care of it, but I can save money somehow. Commercial payers are already doing certain bundles. They have for years. Hip fractures was done 20 years ago by a group in town. State Medicaid programs are going to that. More and more you're going to see state Medicaid programs being managed care. Iowa's just starting. Missouri's not yet, but it's going to happen here soon enough. For quality, they've got sort of the same things: readmission, avoidable complications, adverse effects, care coordination. SCIP is a surgical measure group. And then patient satisfaction. And all these actually, patient satisfaction is a metric. They want to make sure families go home with a smile on their face and not the old HMO days of you screwed me out of what I was deserving to get. With bundled models and long-term care, how do you describe patients to multiple levels of sight? Is it just the fee for service, or are you going to take some sort of percentage down the road? If you have a heterogeneous population, there's home A gets all the simple patients. If your home, which is really good, has a great reputation, gets all the difficult patients, how do you account for that? Your admissions person is going to have to be really sharp in who they take. Adapting PPS to more cost-effective models. Right now, PPS is just how sick can I make the patient look? And that's actually in one of the work plans now. CMS are going to be revamping PPS. Right now, it's almost 40% of people are in the highest RUF group. Really? It was 20% about 10 years ago. People just got magically sicker, or you learn how to game the system, get the most amount of therapy time. There's no timely data. All these things they give you. Look at your MDS data, your quality metrics. It's 6 months ago. That doesn't tell me. When I get my pressure ulcer data, I look at half of them are dead. So I need real-time data. What happened last week to tell me how can I judge what I'm doing now? Seeding and bundled models. One of the big flaws is information tracking. We don't have good information tracking systems in long-term care. You often don't know what you spent until a month afterwards when you tally up all the bills in real time. We defragment care. They come to us and they're in no man's land, right? Does anybody come to your home? Do you ever come in? The PCP, do you communicate with them? How well do you communicate with home health care when they leave? Do you make a real seamless transition? I'm as bad as anybody. I'll complain about the hospital doing a bad transition of care. Do I do a good job of transitioning to home health care? Do we make follow-up calls? Does your home call the patient 2 days later and say, how are you doing? Did you understand your medications? Does home care call you? If they showed up? And if they don't, you get on the phone and yell at the home care worker, get out here now before they show back to my home. What's the benchmark? Is the top 10% right? No. What should we be looking for? Who's going to set that arbitrary benchmark? Managed care organizations are coming big now. In state Medicaid programs are managed long-term care services and support, MLTSS. It's sort of the wild, wild west out there. 16 states currently offer this. When they came into Texas, Texas said, we want managed care to reduce our Medicaid costs. It was about 16 companies that came in. 2 years later, there's 3 standing. So 16 companies signed up people, and over 2 years, they're losing money right and left. Their models didn't work, and everybody's re-enrolling, getting new doctors. Wonderful experiment. Some special need programs are very specific to people. In Pennsylvania, the Medicare care organization designed only for autistic adults that has 90 people enrolled. How can you do actuarial analysis or risk adjustment on 90 patients? Either win or lose bad. CMS is trying to basically align Medicaid MCOs with other integrated plans. There really should be one set of rules. One of the problems now, you got Medicare Advantage rules. You got Next-Gen ACO rules. You got bundle payment rules. You can't figure this all out. There should be one rules that everybody follows with different flavors. MCO issues, they're really inconsistent. Most of the savings really just come from reducing hospitalization, reducing institutionalization costs. When you're at home, you cost less money. They don't tell you that dying is also a good way to save money, but that's a whole other argument. Predicting costs is very difficult. You look at last year's cost. How many of your patients, how many of you can predict the cost of your patient this coming year based on their health problems this last year? Sometimes yes, sometimes no. You got those patients who were healthy last year that go to hell this year. And you got some people that for some reason the problem went away. And the healthcare costs are not as much this year. So how do you expect insurance companies to do that much better? They can sort of actuarially try and adjust for this, but it's very difficult. MCOs leave the market. They don't make enough money, they leave. They're looking for a 20% profit margin. And that's actually the ACA, the rule. The healthcare company can make no more than a 20% profit margin. UHC this year made 22% in our market. They had to return the 2%. Medicare's profit margin is 5%. I don't care what you think about Medicare. Medicare should rule everything. They have the lowest overhead of anybody. All those ads on TV don't come for free. They cost money. Capitation rates is a big problem. Under some of these plans in Texas, they set capitation rates so low they couldn't provide any providers. Some of the plans failed not because they were actuarially flawed. They failed because they couldn't find providers and folded. Who knows what a best practice is in some of these plans, in some of these Medicaid patients? I can't figure out best practice for my patients sometimes. Some of these really sick, dual-eligible patients with multiple comorbid diseases. I have some general goals, but I don't know what the best practice is. I don't know what you do with your life. We also switch practice Wednesdays. My grand idea is I'll switch places with Bill to live, and she'll switch with me, and we'll see who actually did a better job. Do you know what a best practice looks like in your heart? Not really sometimes. Fiscal alignment between Medicare and Medicaid. CMS wants states to investigate more managed care plans, but they also want to use enhanced fee-for-service models. Enhanced fee-for-service models where you get paid something up front but you're at risk. So you get, say, 2/3 of a fee-for-service project, 1/3 we'll wait and see how much you pay your doctor. Would you be willing to be in that sort of model where you took risk? And every quarter you're paid a bonus. And it's not you personally, it's your healthcare system, so they figure out how much you get paid. They take the risk. But it comes down to eventually they're going to get you one way or the other. Nursing home value-based program, the nursing homes are going to be in this game soon, pretty soon. Right now, the nursing home bills either managed care plan that gets their money and argues about number of days, or they do PPS convention and get a whole bunch of money. They really don't have a lot of risk. Starting in 2016, October, they'll be published an all-cause readmission rate that goes on Nursing Home Compare. And by 2018, there'll be a withhold on SNF payments. For every $100, they withhold $2 from the nursing home. They look at their quality metrics and pay them back part of it, depending on how they did compared to the homes. 2% doesn't sound like a lot of money, but that's a lot of margin for a nursing home. That can be the difference between winning and losing in a high-risk market, especially with other capitated payments lowering your profit margin. What they look at for defining value is in your SNF cost. They look at whether you're re-hospitalized, outpatient costs, how much hospice you were referring to, physician cost. If you're discharged, they look at the next 3 days. Immediate bounce backs hurt you right away. They separate long and short-term K on a SNF side, less than 30 days or up to 90 days. The quality metrics, pressure ulcers, falls, and functional status and cognition. We didn't talk about that, but functional status is going to be a quality metric. Where do your patients stand compared to others in terms of loss compared to other homes? That gets touchy because if you take a lot of sick people, they're going to lose function. Are you being penalized? Now, in theory, they actuarially control for that. They know the average 86-year-old diabetic with renal failure and congestive heart failure loses this much function over time. But how well can you predict that? It results to its own kind of cherry picking, a guesstimation cherry picking. I think we can serve this patient well. Potentially avoidable hospitalizations, they'll look at the big ones. Can you keep these people out of the hospital? They look at your survey results, judged by scope and severity. Not only do you get dinged on your quality metrics, even the nurse may get financially dinged on their SNF payments if they're a poor performing home. So there'll be more IDRs or findings when you get a G-level rating. They'll look at staffing data, which is probably overdue. Staffing is a metric that probably was long overdue because homes cut staffing way too often. They'll look at RN and then others separately. What should we be doing in terms of metrics where both of us are in the same boat? If we're trying to drive nursing home improvement, shouldn't we share some metrics? I alluded to this earlier. CMS is looking at hospitalizations. They're going to judge both the doctor and the nursing home and the nursing home itself by rehospitalization. That's something I can help control to some extent. But I don't know about other quality metrics. Urinary incontinence without a care plan? I don't know. Late loss ADLs, pain I may have some control over. And if I don't, maybe I should be yelling at the home. Maybe pressure ulcers, stage 4 and higher. Should I be in there making sure my patients have adequate protection? How many of you sit on your patient's wheelchair cushion? You ever sat on one? I've learned to do that. You need to do that. It's amazing how those things bottom out and nobody ever checks it. And they get a pressure ulcer and you hit yourself in the head and see this thing bottomed out. It's 2 years old. Why didn't somebody look at this thing? Should practitioner services be bundled or unbundled in these systems? Should we get a fee for service adjusted for the quality metrics we provide, or should we bundle it all along and take a higher risk? And what's the role of the medical director in nursing home quality metrics? In theory, a good involved medical director that nursing home appreciates can help a home have better quality metrics. You can help drive rehospitalization costs down. You can save money, right and left. Vitamin D, what are you doing for vitamin D these days? I'll just give you an example. At Belmar Homes, we said to heck with it. Everybody's getting 50,000 units of vitamin D once a month because it's $6 a pill. Vitamin D every day, $4 a pill. Yes, by the time you consider cost of administration and everything. So when you give somebody vitamin D every day, you cost that home $120 as opposed to $6.
Except the 50,000 is more or less becoming associated with this accelerated dementia and more cardiovascular disease. I'm just telling you, that's the endocrinologist in me. Okay.
Right.
So what we're saying is we're doing things for cost. You know, you could argue, in fact, you're better off not giving vitamin D and just take everybody outside, which
exactly
basically makes more sense.
And you can make that argument. And I bring this point just for debate, because I don't know if I'm doing the right thing, but I've said the evidence for me, the evidence for vitamin D is not strong enough that I'm going to waste money. My level of evidence-based dementia is here. Evidence-based vitamin D is here. And I just don't see the cost savings overall. I don't see them saving dementia, hip fractures. Does it really make a difference?
Hip fracture most probably yes. And the data is not bad for hip fracture. In the nursing home, not necessarily in the community, but in nursing homes. So, I mean, it's very complex, and, you know, things change by the next study, we understand.
Right.
But it's very difficult.
That's an example of a decision you're going to have to make for your system. More and more, you're going to have to look at the cost of what you're doing.
So speaking financially, what's the medical director worth financially? What should we be bargaining for?
What the OIG says you're worth is how many hours you work.
How much are we worth each hour?
Your going rate in the community. If you can determine what the average doctor that does administrative work is doing your community, $100 an hour, $200 an hour, whatever it is, that's what you should be charging, you should be given a time clock. If they come and audit you, you should be able to give them roughly some estimate, I work this many hours a week on average. You have to get a time clock. You should be able to justify those hours.
What do Medicare HMO doctors on the phone, what do they make per hour? You know, the ones we have to call peer-to-peer review, any idea?
More than you make.
Up to
More than you make.
Joe,
They don't
it's
answer
getting
the
late.
phone.
We need to move on. Okay.
We're winding down here, but we need to make sure we have quality-based incentives. We fit general quality-based incentives. Right now, a lot of incentives go for outpatient work. They don't look at us, and we can't be judged by outpatient measures. We need best practices written for us. I brought up vitamin D to be antagonistic to John Tensi because I knew you were going to say that. What is the best practice? Do we have data out there that says what really a best practice is? And then can we follow it? Can we change when it changes? How quick do we change? Can we really risk adjust to account for our population? Risk adjustment is going to be a real big area in the future of research. How can we actively risk adjust so people get not only paid fairly, but more importantly, the patient gets treated right for what the conditions they have. Risk adjustment is not just about payment, it's about determining what treatment that patient gets. And what they don't get, more importantly. Should you dialyze a 95-year-old demented patient with congestive heart failure? We don't know the answer. We have evidence for it on outcomes. Aligning physicians with other quality metrics, whether it be the nursing quality metrics, the hospital quality metrics for the patient. If you're going to be judged, you're going to be judged. You want to be judged fairly. When you talk about cost and resources, are we comparing apples and oranges? If I'm being compared to outpatient costs, that's not fair. Do I, on the other hand, want to be compared to Mayo Clinic costs? Not necessarily. End-of-life costs are all over the board. A quick aside, Mayo Clinic and Cleveland Clinic spent half as much the last 6 months of life as does UCLA and Harvard. None of those people are slouches. Somebody's figured out a better way to do something. And we need more of that metrics. Dartmouth Atlas of Healthcare, if you want to get into numbers, just Google Dartmouth Atlas of Healthcare. It's a wonderful treasure trove of data you can pull down who spends what money and figure out who's doing best practices. And best practice doesn't always mean spending less money. There's a great example of a pediatric specialty clinic that sees 8 patients a day and that's it. 1 patient an hour. And they're saving the system money because they keep people out of the hospital to higher levels of care. That's why we've elusively looked at geriatrics. How can we replicate this in geriatrics? What are the high-risk people that go out? How do we keep them out by spending a lot of time with them? Are we throwing the right resources in? It's always been the question.
Chuck, I hate to do this, but some people have to go to another meeting.
Yeah.
Just
Right now, this is the last slide. Become involved, basically. Don't sit on the sidelines. The numbers don't make a lot of difference to you. You don't have to know what you're being paid. But realize we have to be interested in value. We have to know what we're spending. We have to have some idea of whether it's providing value. We have to consider evidence-based medicine in light of quality. Can we afford what we're spending? Lipitor for primary prevention comes up to $2 million per life saved for primary prevention. They don't tell you that on the ad. Can we afford this as a society? You need to be more politically involved in this because somebody else will decide for you, and that's never a good thing. So the happy news is you're all going to make good money and retire healthy. Thank you.
Are you in my way? I was going to ask you how you told the difference between cozy and silent. Because he looks just like cozy.
Yeah.